afternoon, dear colleagues. First of all, I would like to thank the conference organizer for the kind invitation extended to speak up at the Russian-Finnish Congress Symposium. Oh, it's very difficult to discuss all the news in this area of expertise within 10-minute period. That's why I would like, I'm going to be very brief, and I'll touch upon just the major issues we neurologists and neurosurgeons are concerned about. Several issues that prompted pharmacologists and clinicians to use like new modalities. Warfarin, well, is a drug of choice for patients who are indicated anticoagulation. So I'm going to be talking like a small proportion of patients who suffer from atrial fibrillation. As of today, there were several randomized clinical trials conducted studying endrasaban and other modern novel anticoagulants that were compared with warfarin as a golden standard for treating or preventing thromboembolic events. What's known, rivaroxaban, a very good drug. I'm going again to touch upon just the most important issues in the connotation of the cerebral problem. Rivaroxaban is a wonderful drug that, unlike warfarin, doesn't cause hemorrhages, intracranial hemorrhages. However, compared to warfarin, the combined and strokes and ischemic stroke as well as thromboembolic events were not more successfully treated as opposed to warfarin. Next novel drug, apixaban. Is it superior to warfarin? No. Yeah, like the previous novel anticoagulant, number of intracranial hemorrhages and hemorrhagic strokes were fewer as opposed to warfarin use. And even systemic thromboembolic events were seen less frequently. The bigatran, since it has two dosage in Europe at least. In the US, just one dose, 150 milligrams, is approved by FDA. And that's why we have a lot of, we can draw upon this information regarding GI hemorrhages. Let's compare this new oral anticoagulant with warfarin in the, again, the Russian and European dosing. The bigatran is very good from point of view, again, of reduction of intracranial hemorrhages and hemorrhagic stroke. But what is the major advantage? It reduces the risk of ischemic stroke and systemic thromboembolic event. And as of today, this is what makes dibigatran different from other anticoagulants, which is used by clinicians, in particular in the Russian Federation and the Russian Cardiology Society, Russian Internal Medicine Society, and their guidelines emphasized, this appreciated property of abigatran and recommends, as you see on the slide, the following: if with the use of abixaban or anything else, so we see ischemic stroke, doctor should or can consider the opportunity of switching to the bigatran 150 milligrams bid twice daily. And this recommendation is supported with evidences. Well, prevention of repeated stroke is a much more complicated task, just because the situation is associated with higher risks of cerebrovascular events. And again, blood flow patient who already underwent this event is different because of impaired regulation. What's interesting here? Meta-analysis, no, sub-analysis of the RELY trial showed that the patient with a history of stroke compared to warfarin arm rate of systemic thromboembolic events was lower, 25% lower with dabigatran, 150 milligrams twice a day, due to reduction of the hemorrhagic stroke. As for the repeated ischemic stroke, well, the dabigatran was not superior to other anticoagulants in this particular sub-analysis. A rate of large, significant bleeding was much lower for the dabigatran 110 milligrams twice a day, and it was comparable to that with dabigatran 150 milligrams twice a day. As for intracranial hemorrhage, was seen much less frequently for both dosing, regardless of history. In 2013, that's meta-analysis of 3 randomized clinical trials published in Lancet 2013. That's a combined position of oral anticoagulants is better than warfarin. Maybe because of dabigatran and rivaroxaban twice a day. They turn out to be like the winner of this meta-analysis. And in 2012, FDA study of 133,000 patients. It's not a randomized clinical trial. That's a real practice or operational research. So indeed, Pradaxa dabigatran 150 milligrams a day turn out to be most efficacious in terms of preventing ischemic stroke and safe in terms of intracranial hemorrhage. However, major GI bleeding, as you see, was encountered not less frequently as opposed to warfarin. And very important issue, acute MI. So many trials were conducted, well, actually, many attempts were made to study dabigatran or implicate dabigatran in impairing coronary blood flow. Again, the sample size is very significant, but it turned out that dabigatran was not was as safe as warfarin in terms of coronary events. 2013, that's a combined, again, analysis of oral anticoagulants. That analysis showed that, that's, and actually follow-up is rather impressive, significant, 6.7 years. And there were 2 trials devoted to it, RELY and RELY-ABLE. Well, and indeed, that drug turned out to be efficacious, it has a good profile, and it's well tolerated. And we are talking dabigatran. And as you see, number of strokes and systemic thromboembolic events, and then 150 milligrams twice a day. Again, there's statistically significant differences. Dabigatran was superior to other oral anticoagulants, and other, and the last but not the least trial reported or published in Lancet. Again, ischemic stroke, what oral anticoagulants are considered efficacious, more efficacious as opposed to warfarin? Just the Bigatran, 150 milligrams twice a day, in terms of preventing ischemic stroke. Again, that is a combined group or arm of um, primary and repeated stroke. As for major bleeding, uh, basically there are no advantages. Intracranial bleedings, again, thanks God, with the use of new novel oral anticoagulants, so intracranial bleeding is encountered less frequently. And again, this meta-analysis of GI bleeding shows that warfarin is better, superior to novel oral anticoagulant. At least they are not superior to warfarin in terms of GI bleeding as a complication. To conclude what has been said, efficacy of drugs depends on pharmacokinetics. And while thinking of the dose, we have to take into consideration like various parameters like peak concentration and plasma that actually reduces the risk of thromboembolic event in case of discontinuation of treatment or default. Well, as for taking anticoagulants once a day is fine from point of view of compliance, but it's an important point. But the pharmacologist should be thinking of again the ratio of peak and minimal plasma concentration, and if it's to 10 to 1, what does it mean? That's a potential risk of taking rivaroxaban towards the end of the first day. Coming back to like news in this area of expertise, 2013 antidote for dabigatran. That's a first phase clinical trials. The fragment of monoclonal antibody with a high affinity to the dabigatran. And, and in fact, tolerability and safety were demonstrated. It's an important news from my point of view, even though every time when we, put blame on new novel anticoagulants, so we say, well, we don't have antidotes. Okay, do we have an antidote for warfarin? It's not available, at least in Russia. So we look forward to the antidote in the Russian Federation to be made available to us. Thank you for your attention.
Questions, please. I have a question to Finnish colleagues. How Xaralt, Pradaxa, these medications are pushing away previous anticoagulants, namely warfarin, for prophylactics in fibrillation and in treatment of venous-associated thromboembolic event. How new
I can maybe say something regarding the vascular surgery patients. We see quite a little number of patients with the new anticoagulants. Maybe we are a little bit afraid of lacking the antidote that I was very, very interested to hear that maybe coming, especially in considering dabigatran. When it comes to prophylactic, for example, in hip surgery or knee surgery, I know that these new anticoagulants are quite widely used. But when it again comes to venous thromboembolisms, not so much. But maybe some of my neurology colleagues could say some words about the things with prophylactic in stroke patients. Do you, Lauri, have any opinion?
Можно я могу дать свой микрофон, если получится.
Yes, the new anticoagulants have many good arguments for them, but I think they are slowly making inroads to the market, and not that fast as the marketing companies would want. And at the Department of Neurology, we still favor warfarin at the acute stage and low molecular weight heparin, because there is no experience of their use at the subacute stage. And I think we know the good arguments for them, but at this stage it's good to be a bit careful with their use so that you know what you are doing. So I think they are going to a great extent replace warfarin, but we are far from it at this stage. Also at this stage, because they will be more expensive for the patient. That's one argument also in practice.
It's an important argument.
One more question, Alexander. Thank you very much for your speech. After hemorrhagic insult, at what stage this dabigatran can be safely prescribed? We analyzed literature data, our personal experience of Herman Urich in surgery. The first point, their opinion of producers reflected in the indication. In hemorrhagic stroke, it can be prescribed only in 6 months. But in real situation, in fibrillation patient, stroke happened. Cardiologists stand at the bed of this patient, and the cardiologist is saying he has fibrillation of the atrium. It should be administered this oral anticoagulant, and neurologists may say it's impossible to administer these oral anticoagulants because this patient has had stroke. Sometimes it's no clear recommendation. We should be very intuitive. We should study the tests, coagulation tests, the data of MRI, of CT, and in each individual case, the decision should be made customized individually, especially a patient with valve fibrillation of valve-related fibrillation of atrium. Now there are no clear recommendations in this case.